Yeah, very good. Welcome to this RRR series on teaching learning assessment methods. This video is basically on teaching learning assessment methods, and we will be solving some of the MCQs, that is SBS and EMQs. So this is the first scenario. So you can see that here. This is the lead-in. If you are leading a workshop for junior trainees on improving patient safety in the labor ward, you gather the group in a room and ask them rapidly, share all possible ways to reduce the delays in performing emergency cesarean sections, and you encourage quantity of ideas without any criticism. So these are the options. So we can choose one from these options. So here basically, we are inviting ideas, right? And we are going to discuss those ideas, and we are to jot down those ideas, and we will be discussing with each other with the interactive type of session. And this type of this one is called as, it is actually called as brainstorming. Okay, so brainstorming means it is a problem solving technique. Okay, it is a problem solving technique. It involves a spontaneous contribution of ideas from all the members of the group. So you can mulling over an idea of one or more individuals in an attempt to devise or find a solution to a problem, right? So if there are multiple individuals sitting in a meeting room, we all invite ideas first. Okay, so we all give our ideas. All these ideas will be noted down, and then all these ideas will be discussed one by one. Then we will see the advantages, disadvantages, and finally come to a conclusion. So this is called as brainstorming. Okay, so this is the scenario. A leading workshop for junior trainee on improving patient safety. So they do the brainstorming, inviting ideas how to improve the patient safety during emergency cesarean sections. So this is brainstorming. The next scenario is a multinational expert panel is tasked with developing consensus criteria for diagnosing preeclampsia before 20 weeks of gestation. Each member completes an online questionnaire anonymously. Results are summarized and sent back for multiple rounds until agreement is reached. So you can see there are multiple experts who are gathered, not in the same place. They are in their place. They are gathering questionnaires and answering them, and giving those answers to a facilitator who will not disclose the answers to others, but he will recirculate the questionnaires, and then the answers of other expert is shared with the other, and then the same questionnaire is shared with the examiner expert, and then he will again share the answers back. So with this, modifications will occur in the answers, and based on the others what who has shared. So till a common consensus or an agreement is reached, this type of technique is called as Delphi technique. So here experts are independently completes a structured questionnaire about a diagnostic threshold, for example, or on deciding a treatment target, or on the timing of the delivery, etc. So this questionnaire, when they share, they will answer. Okay. Responses are usually anonymized. Then they are collected but shared with the panel, these responses. Once each expert goes through these responses, anonymous responses, so this is a first round of answering. Then when it is returned back, they will again answer back. So the overall answers are returned back, they will again answer back. So till this, multiple rounds of questionnaires will go on until a clear consensus regarding, for example, diagnostic thresholds or treatment targets or timing of delivery is reached. then it is published as a recommendation. So usually it is used in OBG for guidelines development and research priority setting, etc. So while brainstorming is face-to-face, open-ended, and it is not anonymous. This is anonymous, it's not face-to-face. It involves experts. Okay, we'll discuss about PBL later. The next scenario is during a 1 hour clinical session, trainees takes turn to ask others another question in a gamified game show format. So they will ask one group, they will ask question to the other group. The other group will answer. Then the other group will ask question to the first group, and then they will answer. In each round, this is exchanged. Okay, it is facilitated by a facilitator or a surgeon, whoever is doing those rounds. He will facilitate it. And this type is called as actually donut rounds. Okay, so donut round is not exactly something related to eating, but once a surgeon who published this paper conducted this type of rounds, so divided his interns or residents into two groups, and in one round the first group asked the question to the other and the scoring was done. Then the another round, the second group asked the question to the other and the scoring was done. So this prompted active learning in them, and competition enhanced the learning. So while this was happening, he was literally eating donut is what he said in the paper. So this type of rounds is called as donut rounds. The next scenario is at a hospital education day, two consultants actually are debating the pros and cons of universal screening for group B streptococcus while seated in the center of the circle, and these trainees are sitting around them listening to this discussion. They then swap into the middle to join the debate. So basically, there is some discussion or role play going on. The others who are sitting in the periphery are looking and trying to imbibe what is going on, and then they exchange. They also participate in the discussion. This type of, you can see the outer circle, the participants are sitting. This is like a bowl. Inner circle is like a fish. Okay, so they are having a moderator will be there, chairs will be there. They will be discussing or doing role play. So this is like a inner group of discussion, which is observed by an outer ring with rotation of the roles. And this is called as goldfish bowl, an analogy used. It encourages focused dialogue between the participants and those who are in the outer ring. It encourages active listening in them. Okay, while brainstorming is an idea generation, donut is related to quizzes, and PBL is related to problem solving, and this is related to discussion and exchange of roles. Another EMQ scenario is a consultant obstetrician delivers a 40-minute presentation with the slides on the latest RCOG guidelines for induction of labor. That means he is delivering a presentation on latest RCOG guidelines. That is, he is an expert on induction of labor, speaking to an audience of foundation year doctors. That means some people are listening passively while an expert is talking. This is a classical lecture, which is didactic, expert-led presentation, usually one-way communication, and there is only transfer of information and there is no active interaction. There is no deep analytical or critical type of learning. This is the classical lectures. While it has its advantages in transfer of information, especially by an expert to an audience in some amount of time, the disadvantages are all listed here. Another scenario is a group of medical students is presented with scenario of women presented at 28 weeks with vaginal bleeding. That means they are given this scenario. What they need to do is they should go through the scenario. They should identify what are their learning objectives related to this. Then they should find their own research resources. Then they do the research or learning. Then they have to reconvene to discuss this. Then again, the cycle repeats. That means here a particular problem is given. who's see, you can see the particular problem is given, and by brainstorming they find out the specific learning objectives. They also can do concept mapping or mind mapping to find out all this. Then they formulate the learning goals. Then they find out where they have to learn about this. Do they have to visit the OPD wards or emergency section or OT, or do they have to read some books or see some videos or attend some workshop, whatever? Then they again do the self-directed study. Okay. Then when they come back, they sit, okay, and discuss, and then again reconvene, reflect upon them, and see what other objectives are remaining. Such sessions continue. So this type of active student-centered approach, where a clinical problem triggers self-directed study in a group, and this particular cycle continues till they learn everything about a particular problem, is called as problem-based learning. Okay. While in traditional learning, we are told what we need to know. Here the problem is assigned in problem-based learning. While in traditional learning, we memorize it. Here we only find out the objectives and resources. In traditional learning, problem actually is assigned to illustrate how to use this knowledge. Whereas here problem is assigned first, and then through this we learn and apply to solve the problem. That is the difference in problem-based learning. The another scenario is, before teaching operative vaginal delivery, the facilitator asks the trainees, you have to recall and share everything they already know about the prerequisites of forceps application. That means knowledge is being sought, that is memory is being tested, and they are asked to recall. That is a schema of knowledge is getting activated by these questions. So the schema are nothing but these are eliciting existing mental frameworks. Okay, already existing mental frameworks. Whose when recall is queried, it improves retention and integration of the new topic, and it helps the trainers to assess the baseline knowledge of the group which is going to participate. Okay, before adding any new knowledge or making the learn effective, we will elicit and the recall of the existing mental framework. This is called as schema activation. Whereas schema refinement, it actually happens after learning to adjust to the already present schema. Okay, we'll see that. Lecture or brainstorming does not necessarily involve linking to prior knowledge. Another scenario, a simulated forceps delivery session is being planned or conducted. The facilitator initially reviews the video footage and corrects the misconceptions. He helps the trainees fine-tune their existing knowledge and then integrate this new evidence-based practices to their forceps delivery session. So here you can see already existing knowledge is getting modified and is improved. That is, it is the present existing mental framework, that is a schema, is getting modified or improved or refined after feedback or finding of the new evidence. It usually helps to correct our misconceptions after we perform the simulation. Then again, when we end up performing the simulation, we may it may improve the accuracy in complex decision making in actual real settings. So this is schema refinement. So schema activation is pre-learning, and it is not a post-practice correction, whereas schema refinement is post-practice correction. Another EMQ scenario is, a student is learning to insert a urinary catheter in a pregnant woman. The procedure is broken down into 3 basic steps: patient preparation, insertion of the catheter, and securing the tube, to make it easy for a beginner to follow. That means a procedure is being shown and a facilitator is showing it. There is a hierarchy. There is not much explanation given here, only observation and some feedback, also very minimal. So this is called as simplified procedural hierarchy. That means it's a very basic, minimal step breakdown of a skill, and it is ideal for novices. Why not complex? Because in complex procedural hierarchy, it involves many sub-steps and decision points for advanced learners. We will see how. This is another scenario. In a small group tutorial on perennial tear repair, each student first writes down 2 key principles individually. Then they pair up to share their lists, join another pair to form a group of 4. Then they finally share the consolidated ideas with the whole class. So it is snowballing. That means initially it starts individually, then they discuss in group of 2, then they discuss in group of 4, etc. That means progressively expanding the group discussion, the intensity of the discussion also increases. The content, depth and breadth of the discussion also increases. While brainstorming is a group-wide from the start, here the groups are formed slowly, like as when the snow ball increases when it starts to rotate in size, it starts to increase. Similarly, the content, depth and breadth of the discussion also increases as the group size goes on increasing. Delphi is not a face-to-face iterative session, whereas snowballing is. You can see regarding the perennial tear repair is the problem they are trying to solve. So individually they think, they pair up, then they pair up again with a group of 4, etc. Then the consolidated is shared with the class. And this is called as snowballing. Now here is a registrar is learning to perform a total abdominal hysterectomy, some procedure. The trainer breaks it down into multiple detailed sub-steps from patient positioning to closure with attention to complex decision points at each stage. Okay, so that means each stage the registrar or the teacher is assessing the trainee. At each stage, his performance, skill, and communications are noted. Feedback is given. Once he reaches a point of efficiency, he will be allowed to do the skill or procedure independently but under supervision. And later, completely independently, he may be allowed to do. So there are multiple checkpoints here. There is a hierarchy of teacher showing the procedure and then trainee trying to following it. But this is not a very simple procedural demonstration where simple demonstration and the trainee observes and learns. There are complex set points involved here. At each step, assessment, feedback, and refinement happens. And this is called as complex procedural hierarchy. The difference is simplified hierarchy. There are very minimal steps and it is for beginners. And it happens in very short amount of time. The complex procedural hierarchy, it is a detailed step-by-step sequence for advanced skill learning with multiple complex set points of assessment and learning. And it happens in a progressively in a long duration of time, say 1, 2, 3 years, where residency programs are examples. Next lead-in is, it's a summative assessment tool. It will help to assess the cognitive psychomotor skills as well as attitude domain on the whole curriculum wide areas. So which is that summative assessment tool, which will assess the knowledge also, skill also, and also the attitude of the surgeon or whoever is trying to give the assessment exam. So which amongst this is the assessment tool? ARCP, NOTS, OSATs, all these are assessment tools, but which among this is helping to assess the cognitive psychomotor? It is ARCP. That means annual review of competence progression. Here, annually, a review of progress in the competence achievement of the residents is done by a team of experts in a committee, and they are meeting to see whether curriculum competencies are certified or they are met by the candidate, whether there is a gradual and visible successful progress in achieving these milestones to reach the competencies, or does he require any additional training or support, and the decision whether he can be progressed to the next training level, second year or third year. All these are taken in this annual review of the competency progression process. So usually what is evidenced during annual review of the competency progression process, they review multiple things like workplace based assessment performance, their logbooks, supervisor reports. They also review the multi-source feedbacks, his training portfolios, reflection and learning methods, and audit and research activities, to say so. All these are reviewed to finally take a decision on his capacity to meet and progress further. It's a summative assessment tool. Another is a formative as well as summative assessment tool according to MRCOG EBCOG guidelines, and it is a workplace-based assessment tool, actually to evaluate the technical skills of a surgeon. So what is this tool, which is both formative and summative, and assesses the technical skills of a surgeon? And it is nothing but OSATs. The full form of OSATs is objectively structured assessment of technical skills. These are one of the workplace-based assessment tools. That means these assessments happen at the workplace, not away from the workplace, not in other simulated scenarios. And these are used in OBG trainings. These are validated assessment tools, and many checklist tools are available here, which assess your technical competency of a particular technique. So based on the technique, these checklists are prepared, and it can be used for formative learning with feedback, and also as a summative assessment tool to assess and allow him to grade or rank or graduate. Another type of assessment technique which is used to check communication as well as teamwork, situational awareness, how the decision-making capacity of a trainee, leadership qualities, and whether he is managing the task properly or not. And this type of assessment technique checks all this. So what is this assessment technique? And this assessment technique is actually checking the non-surgical skills of the surgeons. That means NOTS, that is non-technical skills for surgeons, is assessed. For example, whether the person is aware of the situation, like whether he gathers the information, whether he understands what is happening, whether he anticipates future events, his ability to make the decision, considering all other options, selecting the actions and reviewing the outcomes, his communication with the teamwork, exchange of information, coordination with the team members, and his leadership qualities like setting the standards in role modeling and supporting the team and coping with pressure. So there are several checklists available to check these non-technical skills for surgeon, and it is also one of the workplace-based assessment. While, for example, a surgery is being done, the observer can observe for all this. Another session is a trainee performs forceps assisted vaginal delivery under supervision. After the procedure, the consultant conducts a feedback session. Now the consultant first asks the trainee what went well. The trainee reflects, and he reflects several positive points. The consultant then agrees and adds additional strengths to those. Next, the consultant asks what could have been done better by the trainee, and the trainee again reflects and identifies what he could have improved. Then consultant will add further suggestions to it. This is a standard feedback model. And what type of feedback model is this? And this is nothing but the feedback model of Pendleton techniques. There are other feedback models like sandwich technique, etc. But this Pendleton techniques involves particular steps like ask the learner how they felt, ask the learner what went well and why do they think it went well. So the learner themselves reflect about their feelings and about what went well and why it went well. So it promotes reflection in the trainees. Then the teacher will also say what went well and why. And he will also ask the learner what could be done better and how. So he will seek the solutions from the trainee themselves. Of course, the facilitator can add. Then he will summarize all the strengths and what he needs to concentrate. Of course, it is done with the student for verification. This type of active feedback technique is called as Pendleton's feedback technique. Now we will see some single best answers. A consultant is teaching a trainee how to perform episiotomy suturing. First, the consultant performs entire procedure without telling anything. Next, the consultant repeats the procedure while explaining the steps. Next, the trainee is asked to describe the step while the consultant is performing episiotomy next session. Finally, the trainee themselves are given to perform the procedure independently and allow with explanation. What type of teaching method is this? So this is nothing but Payton's 4-step framework. This is not Pendleton feedback technique. This is Payton's 4-step framework. Okay. This is Payton framework. Okay. Payton's framework. So what is this Payton's framework? First, it involves demonstration of the skill. Teacher demonstrates the skill. Next, while demonstrating the skill, he will tell the procedure step by step, deconstructs it. Then he will seek the understanding of the learner. While the facilitator is demonstrating, the learner will explain the steps. Then the learner will perform and explain the steps. These are the 4 steps of demonstration, deconstruction, and comprehension and performance that is involved in teaching a particular procedure. And this is called as Payton's framework of teaching the procedural skill. Payton's framework. A junior obstetric trainee observes a senior consultant managing a PPH. The trainee later reports that observing the consultant's actions and decision making actually helped the trainee to understand how to manage a similar situation in the future, even though the trainee did not actually perform the procedure. So which learning theory best explains this process? It's a learning theory. That means he is learning from observing a senior consultant. So this is nothing but vicarious learning. Vicarious learning occurs when individuals learn by observing others' behavior. Here, as in his experience, while he is speaking, the learner is seeking learning from it. It is derived from social learning theory and is common in clinical settings, where trainees learn by watching the experts, how they are managing the patients, how they are performing the procedures, how they are communicating. So they observe and learn by another person, learn from another person's experience. Another SBA, here a trainee manages a patient with eclampsia, trainee is managing under supervision. Now, after the case, the trainee actually reflects on what happened, how did he manage. He goes back and reviews the guidelines and he later applies this knowledge and encounters a similar patient later. Which learning model best describes this process? Here, the trainee themselves is learning by their own experience. So this learning model is experiential learning, in which it occurs from direct experience, followed by reflection and applying the learning from the reflection into the next situation when arrived. So see, this includes concrete experience, that is he himself is performing the managing the postpartum hemorrhage, for example. After that, he will reflect upon what went well, what did not go well, and how he needs to improve in future. And he will abstract conceptualization is done to see whether he has learned or not. In the next cycle, he will actually experiment this learning. And this is called as experiential learning of COB. These are the COB-based cycle of experiential learning. Another scenario is a trainee initially believes that all prolonged labor must be managed with immediate cesarean section. That's his belief. But after getting exposed to evidence-based teaching and reflecting on several clinical cases and discussing with the mentors, the trainee fundamentally changes his understanding and adopts a more balanced managed approach that all prolonged labor need not be managed with cesarean section. So which educational theory best explains this learning process? It is here transforming the basic concept in a person. So transformative learning, it actually occurs when learners critically reflect on their assumptions and presumptions, and later, while they undergo the experience, they actually changes their underlying beliefs or perspectives. So key feature here again involves critical reflection on the part of the trainee, which will challenge his or her existing beliefs or presumptions and assumptions, and leading to transformation in the perspectives. It is called as transformative learning. So there are three main learning processes. Vicarious learning is by observing others. Experiential learning is through by direct experience and reflection. Transformative learning, it will change in beliefs and perspectives after critical reflection. So these are the differences. Another SBA, a postgraduate examination in obstetrics selects the top 30% of the candidates on their scores relative to each other. Even if most candidates achieve high score, only the highest performing group will pass. So which type of assessment method is being used? So it is norm referenced assessment and not criteria referenced assessment. So this answer is actually norm reference based assessment. That means in the norm reference based assessment, here learner's performance is compared with that of the others. If all the others are performing poorly, even an average person will be selected. If all the other persons are performing very highly, then even an intelligent person may not be selected, because it is relative, performance is relative to others. For example, interviewing, ranking of the candidate, passing only the top percentiles are all norm reference based assessments. Here the performance of the group affects the final performance of the individual. Now, another type of assessment in which a clinical skill examination requires trainee to demonstrate predefined competencies are set. Any candidate who achieves this required checklist passes regardless of how other candidates perform. Here the performance of the other candidates is not influencing the performance of the individual. But when they see whether basic minimum competency is met or not. And this type is called as not norm referenced, and this type is called as criteria referenced assessment. Here in this criteria reference assessment, a fixed standard competency against which assessment is done. For example, objectively structured clinical examinations, a pass mark is set by a standard setting method. And other competency based training assessments, they are all examples for criteria referenced assessment. So in comparison, norm referenced assessment, the performance of one is compared against the others, whereas in criteria referenced assessment, it is compared against a predefined standard. The purpose is to compare and rank, whereas it is to see whether competency is achieved or not in criteria referenced. Only a fixed portion will pass here. Anyone who meets standard can pass in criteria referenced methods. ASCII is an example. Percentage is an example of criteria, whereas percentile is an example, and interviews are example of norm reference based settings of assessment. Now, which level of Miller's pyramid of clinical competence does the simulated performance show? Simulation. In the simulation skills lab, there will be simulation guidelines will be set up to see endotracheal intubation. Now, this actually shows how. Okay. So you can see the lowest level in the Miller's pyramid is checking the knowledge. Then is application of the knowledge. Then skill demonstration in non-workplace simulated setting. Then the skill demonstration in the actual practice or the workplace setting. So, okay. So that is a knows is memory, knows how is application of the knowledge, shows how is in a simulated setting, and does is actual practice. So that is what it checks. That is a Miller's pyramid of clinical competence in simulated performance checks, shows how level of the Miller's pyramid. A trainee is asked to critically evaluate different management strategies for placenta previa and justify the best approach. Here, what is being tested? Knowledge, understanding, comprehension, application, analysis, or evaluation. Here you can see evaluation is checked, and this is the Bloom's taxonomy. If you are asking what are the causes of postpartum hemorrhage, you are checking the memory. If you are asking why postpartum hemorrhage occurs, you are checking is understanding. And you are asking how you apply this knowledge to manage the patient is application. And the report, if you are asking to analyze and evaluate, and that becomes this highest level of setting, you are checking the highest level of the Bloom's taxonomy of cognitive domain. A hospital introduces a training workshop on management of obstetric emergencies. The organizers measure whether patient outcomes improved after training. That means a program evaluation method, Kirkpatrick evaluation model is now being used. Now here in this, are they checking the reaction? Are they checking the learning of the learner? Are they checking the change in behavior? Are they checking the output results? Are they checking the actual participation in the workplace? Here in this case, the organizers actually are measuring whether patient outcome improved after training. That means they are checking the results. Okay. So if you ask a question on what did you feel after undergoing the training, was it useful for you? That question is checking the reaction. If you ask what did he learn by doing pre-test and post-test, that is checking the learning. And if you ask, did it change your behavior? That is checking the impact. And if you see actually it is improving his performance, it is checking the results. That is on the patient outcome. That means whether the patient improved and got discharged correctly or not in the actual practice. How many patients who are treated by them actually did not have complication. They are all results that has been because of the impact in the actual scenarios. Okay. So these are the 4 levels of Kirkpatrick's levels of program evaluation. A consultant directly observes a trainee taking a focused antenatal history, examines the patient and immediately provides structured feedback. Here a workplace-based assessment is being used. Here there is an observation of the performance and with a standard checklist, and this is called as the mini clinical evaluation exercise. Here what is being observed is all this can be observed. That is history taking, physical examination, whether how he counsels or not, what is his clinical reasoning, and the others, including professionalism. Okay. So this is called as mini clinical evaluation exercise. It will assess the skills in real patient encounters with direct observation and feedback. Whereas in direct observation of procedural skills, only procedure related feedback is given, not the all this. This is clinical evaluation exercise. That is what is being done. You can see here, though the word directly observed is coming, but what is being observed is taking a history, examination, Okay, and then providing the feedback. In DOPS, only procedure, direct observation of the procedure is done. A trainee is observed while performing amniocentesis, and the assessor evaluates technical skills using a checklist. That means a technique is being observed using a checklist. And this is what I discussed in the last. The procedure or a checklist procedure is observed directly using a checklist, not necessarily history, counseling, etc. So DOPS is direct observation of procedural skills in real clinical procedure scenario. Authentic. Okay, this is another example of workplace-based assessment. Okay, so all this can also be checked in DOP apart from mini CX, but basically they check the procedures. A trainee discusses the management decisions made during complicated ectopic pregnancy case with a supervisor. A trainee is discussing about the management decisions of a particular case in detail, which workplace assessment is being performed, while the supervisor is observing and noting down how he is discussing on the case. It's case-based discussion. It actually focuses on mainly how he has recorded the case. Okay, what is his clinical assessment, how he is getting the investigation and referrals, and how he is writing the treatment, what is his follow-up, etc. Basically, more about the case, clinical reasoning and decision making using real cases. This is case-based discussion. Whereas in mini CX, they check the history taking, physical examination, and also other things. In case they clinical reasoning, decision making, and which investigation and treatment they use, all those related to the case, what could be the complications, that thing is checked in case-based discussion. A trainee receives structured feedback from consultants, nurses, colleagues, and patients regarding professionalism and communication skills. Which assessment method is this? That means a structured feedback from not one person, but many persons, consultants, nurses, colleagues, as well as the patients. So you can see feedback is multi-source, and this is called as multi-source feedback, which is also called as 360-degree assessment. It actually evaluates the professional behavior and also the teamwork. Minimum 10 to 12 valid responses from most of them from the consultants, midwives, nurses, junior doctors, and admin staff, etc. The mix of the feedback should include all this, and the feedback on communication skills of the trainee, attitude and professionalism and teamwork of the trainee, accessibility and reliability of the trainee, and clinical management ability of the trainee is seek from all them. And that is the 360-degree assessment or multi-source feedback called as MSF forms. They are to collect that and present during the ARCP. A trainee rotates through multiple stations where they demonstrate clinical skills such as counseling a patient with infertility and interpreting CTG retraces. Which assessment format is being used? Of course, there is a criteria-based checklists are there in this, and it is very standard and very objective, though not very authentic. It is not a workplace-based assessment. This is the OSCE, objectively structured clinical examinations, which are the stations which you will undergo during your examinations. A trainee notices that although professionalism is emphasized in lectures, some senior clinicians actually frequently disregard the communication protocols in practice. Which educational concept does this represents? Though it is not there in curriculum yet, the trainee is observing this. This is nothing but hidden curriculum. It is not in the formal curriculum. Okay. And it is not experience learning or it is not reflecting. It is the hidden curriculum. That is, hidden curriculum refers to the implicit lessons learned through workplace-based culture and behaviors rather than the formal teaching. Formal teaching happens, informal teaching happens outside the teaching hours. Whereas this hidden curriculum, implicit are implicit learnings that is happening. So that is the difference between other types of learning. So these are some 15 EMQs and 15 SBS on 30 different topics of teaching, learning, and assessments related to EBCOG. I hope this YouTube series was useful for you. Please do subscribe, like, and share this. And these are our contact numbers, and to subscribe to them, contact them. Thank you and all the best.